When you look into a horse's eye, there's just something incredibly captivating about it. Deep, expressive, often reflecting a serene wisdom.
Hmm.
But for all their beauty and prominence, those eyes are surprisingly vulnerable. Today, we're taking a deep dive into a common, yet incredibly serious, equine health issue: corneal ulcers.
Yeah.
These aren't just minor scratches. They're a critical concern for anyone who cares for horses, demanding rapid, informed intervention.
And that's precisely our mission in this deep dive, to really unpack everything you need to know about these particular eye injuries,
Right.
from how they happen to what veterinarians do to treat them, and crucially why acting fast is just so important. We've pulled together the key insights from, comprehensive material on this to give you the clearest picture possible.
Okay, so to start, let's quickly break down the cornea itself. Think of it as the clear front window of the eye. Right?
Exactly.
It's made up of three main layers. You've got the epithelium, that thin, protective outer layer. Then the stroma, which is the thick structural middle layer, and the endothelium, the innermost layer, which is vital for keeping things clear.
That clarity.
So simply put, a corneal ulcer is a defect or a loss of that outer epithelial layer, which can unfortunately extend much deeper.
It can really go quite deep.
So let's get into the specifics of what a corneal ulcer actually is. It's defined as a sight-threatening disease. And that means it needs early diagnosis and immediate appropriate medical or even surgical therapy.
Absolutely.
These can range from, a simple superficial scratch just on that outer layer, the epithelium,
Right.
to a full-thickness perforation. That's where the iris, the colored part of the eye, can actually bulge out through the hole.
Vesicle prolapse right through. It's quite dramatic and
Right.
very serious.
Wow.
And that's why prompt therapy is just essential. These things can progress so rapidly, leading to complications that threaten not just the horse's vision, but frankly, the entire eye itself.
The whole globe.
The whole globe. And what's kind of fascinating here is the horse cornea's unique properties. For one, it's relatively thin, only about 0.9 to 1.2 millimeters thick.
It's not much.
No. And while the epithelium is normally, say, 8 to 10 cell layers thick, it can actually thicken up to 10 or 15 layers after an injury as part of the healing process.
Okay.
But, and this is really critical, the basement membrane, the layer the epithelium sits on, isn't fully formed even 6 weeks after the injury, even if it looks like it's healed on the surface.
6 weeks. Wow.
Yeah.
Yeah.
So even when an ulcer looks healed superficially, the underlying structure is still incredibly fragile. Re-injury is a very real risk, which tells you why extended caution is just so vital. Just for perspective, a 7-millimeter wound in the middle of the stroma, even if it's not infected, takes nearly 12 days just to heal over.
That really paints a picture of how incredibly delicate that window to the world is for them. So why are horses particularly susceptible? Is it just their lifestyle?
A lot of it is anatomy and environment. Their eyes are so prominent, right? Very large, kind of bulged out a bit,
Yeah, they stick out.
which just predisposes them to trauma from all sorts of environmental hazards. We're talking about everyday things, bits of hay, branches when they're out in the pasture, fencing, stall doors, even accidental bumps or kicks from other horses.
Huh.
And foreign bodies like dirt, sand, or plant material getting trapped under the eyelid are also incredibly common culprits.
Makes sense.
And if we connect this to the bigger picture, the equine cornea also has this really strong fibrovascular healing response.
Okay, what does that mean exactly?
It means its natural tendency is to heal with a lot of fibrous tissue and new blood vessels. Now, those blood vessels bring vital healing components, which is good,
Right.
but too much fibrous tissue can lead to scarring and cloudiness, which obviously can obscure vision. So that's where it becomes a bit of a curse as well as a blessing.
Right, a double-edged sword. So trauma is the most frequent cause, clearly. But here's where it gets really interesting and a bit scary. Infection should always be considered possible with every single corneal ulcer in a horse.
Every single one, precisely. Infection develops when there's a defect, a break in the tear film or the corneal epithelium itself, which allows bacteria or fungi to get a foothold and adhere.
And are these exotic bugs or...
Not usually, no. Often they're organisms normally found just hanging out in the horse's conjunctival flora, the normal surface bacteria and fungi.
Yep.
Things like Staphylococcus, Streptococcus, Pseudomonas,
Okay.
and common fungi like Aspergillus and Fusarium species. Those are very common culprits. Even equine herpes virus can cause ulcers too.
Herpes virus, wow. Okay. Now this susceptibility, especially to infection, brings us to something truly devastating that veterinarians call melting ulcers. Can you explain that? It sounds awful.
It is awful. Think of it like this. Certain enzymes, really destructive ones called proteases and collagenase, get released.
By what?
They can come from the horse's own immune cells, neutrophils in the tear film trying to fight the problem, but also from some of those nasty bacteria and fungi themselves. And these enzymes literally start to, well, digest or eat away at the cornea's structural layers, the stroma. This rapid degradation causes thinning, and the tissue starts to look soft and gelatinous, almost like it's dripping or melting away.
Oh, gosh.
And those severely affected corneas are at a huge risk of perforation, meaning a full rupture of the eye.
That sounds like an absolute emergency.
It is. And other things can predispose them to infection too, like underlying immunosuppressive conditions, and crucially, using topical steroids. These are a big no-no in ulcer cases.
Why is that?
Because they dampen the immune response, which sounds good, but they can actually encourage the growth of those bacterial and fungal opportunists and really impair the natural healing processes, like collagen production and epithelial healing.
Got it. No steroids.
Definitely not with an ulcer. Also, fungal involvement should always be high on your suspicion list if there's a history of injury with plant matter, like a poke from hay or a branch. Or if an ulcer just isn't getting better despite using antibiotics for a while. Maybe it started bacterial but got a secondary fungal infection.
Okay.
And don't forget eyelid abnormalities, things like entropion, where the eyelid rolls inward, rubbing lashes on the cornea, or aberrant cilia, which are misplaced eyelashes doing the same thing. Dry eye, though it's less common in horses than dogs, can play a role. And immune-mediated conditions like equine recurrent uveitis or moon blindness can also contribute to ulcers or make them harder to heal.
It's also important to point out that, foreign bodies, chemical burns, and even immune mechanisms can directly cause ulceration themselves.
Okay.
And sometimes a superficial ulcer just stalls. It refuses to heal properly.
Right, the indolent ulcers.
Exactly. What happens there?
Often it's because a tough, non-adhering layer, almost like a slippery, clear film called a hyaline membrane, forms over the wound bed.
Okay.
And this literally prevents the new epithelial cells from sticking down and properly migrating across to close the wound. It's like they can't get traction.
Huh. Frustrating.
Very. And here's another fascinating risk factor that gives us a powerful insight into the whole process. Tear film proteases, those enzymes involved in degradation we mentioned with melting ulcers.
Yeah.
They're actually elevated in both eyes of a horse, even if the ulcer is only in one eye.
Both eyes. Why?
It suggests a systemic stress response, not just a localized problem at the site of the ulcer. And it means that true healing isn't just about fixing the hole in the cornea, it's about the whole body kind of reestablishing balance before those protease levels return to baseline. Healing won't fully occur until they do.
That's really interesting. A whole body connection. Okay, so knowing all this, what does it mean for diagnosing these conditions? What are the practical signs owners should be looking out for?
Right, so owners often notice intense pain first. You'll see that as severe squinting or maybe involuntary eyelid spasms. Vets call that blepharospasm.
Okay.
And the horse might be rubbing at the eye quite a bit. There's also usually excessive tearing, what we call epiphora, plus obvious redness and swelling of the conjunctiva and eyelids.
Makes sense.
Light sensitivity or photophobia is really common. They'll want to keep the eye closed or turn away from light. And you'll likely notice a constricted pupil, miosis. You might also see cloudiness or a bluish haze on the cornea itself. That's corneal edema or swelling.
And discharge.
Yes, if you see a white to cream colored discharge, that usually indicates infection is present. Also, signs of anterior uveitis inflammation inside the front part of the eye are found to some extent with pretty much every corneal ulcer. That can include that constricted pupil again, maybe cloudiness in the fluid inside the eye, what's called aqueous flare, or even fibrin blood or pus collecting in the front chamber.
So lots to look for.
Absolutely. A thorough ophthalmic examination by a vet is crucial. And sometimes because of the intense pain, sedation, or even nerve blocks might be needed just to get a good look.
Okay, and the most critical diagnostic test you mentioned is the fluorescein stain.
Yes, absolutely fundamental. Undiluted fluorescein dye retention is diagnostic. You apply the special orange dye, and it adheres to any areas where that protective corneal epithelium is missing.
So it shows you the hole.
Exactly. It shows up as a bright, unmistakable green under a cobalt blue light. Can't miss it.
Now, you mentioned differentiating this from something called a dysmetasol.
Right, and that's incredibly important. A dysmetasol is a very deep ulcer, basically a crater that has eroded all the way down through the stroma to the very last thin layer called Descemet's membrane.
Hmm.
So when you apply the fluorescein dye, it stains the edges of the crater, the remaining stroma, but the center, which is just that bare Decimet's membrane, doesn't pick up the stain, so it looks clear or dark in the middle.
Why is that distinction so critical?
Because it tells you the globe is at extremely high risk of rupturing. The cement's membrane is only about 21 micrometers thick, incredibly thin. It's the last barrier.
So it's about to burst.
Essentially, yes, it needs immediate, often surgical intervention. Deep ulcers, on the other hand, which still have some corneal stroma, some collagen left at the base, will retain the fluorescein stain throughout the whole lesion.
Okay, that makes sense. And if infection is suspected, especially with these rapidly progressing or deep ulcers?
Then laboratory tests are absolutely essential. You need to know what you're fighting. This means microbial culture and sensitivity testing for both bacteria and fungi.
How do you get those samples?
Good question. Corneal cultures should ideally be obtained first before applying too many other medications. Then you follow up with corneal scrapings for cytology that's looking at the cells under a microscope.
Scrapings. Sounds rough.
Well, you need to be vigorous enough. After applying a topical anesthetic, of course, you use a sterile scalpel blade handle or a special cytology brush to scrape material from the edge and the base of the lesion. This is important to detect bacteria, and especially those deep fungal hyphate, the thread-like structures of fungi. Just doing a superficial swab might miss the organisms entirely.
Right.
And it's also really important to remember that you can have mixed bacterial and fungal infections happening at the same time.
Okay. Good to know. And just quickly, are there other things that cause a painful eye that a vet might need to rule out?
Oh, definitely. The differential diagnosis list includes things like primary uveitis, blepharitis, which is eyelid inflammation, conjunctivitis, glaucoma, which is high pressure in the eye, and even dacryocystitis, an infection in the tear duct. So a full exam is key.
Got it. Okay, knowing what to look for is half the battle. The other half, of course, is treatment. And you've stressed this already, but time is absolutely critical here. Corneal ulceration should always be treated as an emergency.
Always, without question. The horse cornea can deteriorate incredibly rapidly if it's ulcerated, and as we've said, it's highly prone to infection.
So, first steps in management.
First, horses should definitely be on stall rest until the ulcer is healed. Minimize activity, minimize risk of further injury, and protective measures like a hard or soft cup hood or even just a fly mask can be really helpful. They reduce the chance of the horse rubbing the eye, which they often want to do because it hurts, and protect it from further environmental trauma or irritation.
Makes sense. And then the medical management.
Right, that's the first line for many ulcers. It typically involves topically applied antibiotics. There's a range of options, things like neomycin, polymyxin, B-bacitracin, which is a common triple antibiotic, or gramicidin, chloramphenicol, gentamicin, afloxacin, ciprofloxacin, tobramycin, or amikacin. The choice depends on the suspected bacteria or culture results if you have them.
And how often do these need to be applied?
Frequently. Very frequently, especially initially. Depending on the severity, it could be anywhere from every hour to maybe every 8 hours. You need to maintain high concentrations of the antibiotic right there on the cornea.
Every hour. That's intensive.
It really is. And crucially, remember what we said about steroids.
Contraindicated. Absolutely not.
Exactly. Topical corticosteroids are a definite no-go. They can encourage bacterial and fungal growth and mess up healing. What is used commonly is topical 1% atropine.
What does atropine do?
It does a couple of important things. It helps stabilize the blood-aqueous barrier inside the eye, reducing that inflammatory uveitis we talked about. It also minimizes pain from ciliary muscle spasm, that's the muscle that controls the pupil, and it dilates the pupil.
Why dilate the pupil?
It helps prevent the iris from sticking to the lens, which can be a complication of uveitis, and generally makes the eye more comfortable. It's usually given maybe every 4 hours initially, then tapered off as things improve. One note of caution. Horses receiving atropine should be monitored closely for any signs of colic, as it can sometimes slow down gut motility as a side effect.
Good point. Okay, what about those scary melting ulcers? You mentioned special therapy for them.
Yes, for melting ulcers or ulcers showing signs of collagenolisis, infection, or just being chronic non-healers, specific anti-collagenase or anti-protease therapy is vital. This aims to stop those destructive enzymes dead in their tracks.
What kind of medications are those?
Options include topically administered autogenous serum, that's serum collected from the horse's own blood.
Their own serum. How does that work?
Yeah, the horse's own serum contains natural antiproteases that can counteract the melting enzymes. It's quite effective. You spin down their blood, collect the serum, and put it in an eyedropper. Other options are medications like acetylcysteine, usually a 5% solution, or sodium EDTA in a 0.2 to 1.0% concentration.
How often do you give those?
The serum can be given as often as possible, really maybe every hour or two along with the antibiotic. It does need to be kept refrigerated and replaced with freshly collected serum about every 8 days or so, as the factors in it can degrade. And sometimes you might need to use multiple anticollagenase medications together to get the melting under control.
Wow, that is intensive care.
It really is. Alongside the topical treatments, systemic NSAIDs non-steroidal anti-inflammatory drugs like phenylbutazone, bute, or flunixin meglumine, banamine, are usually given either orally or intravenously. These help reduce the internal eye inflammation, the uveal exudation, and provide significant pain relief.
And you mentioned something about a special catheter system for horses needing lots of meds.
Ah, yes, the subpalpebral lavage system, or SPL. This is incredibly useful for horses that need very frequent medication, like every hour or two, or for horses that are particularly difficult or dangerous to treat directly in the eye that often.
How does it work?
It's basically a small, flexible catheter that the vet places surgically under the upper or lower eyelid. The tubing then runs up the horse's face and mane, so you can attach a syringe and deliver the liquid medications remotely without having to pry the eyelids open each time. It makes frequent dosing much, much easier and less stressful for everyone involved.
That sounds like a lifesaver in some cases. Now, what if medical treatment just isn't enough? Or for those really deep, non-healing or rapidly progressing ulcers?
Yeah, in those situations, or if you have a dysmetasal or perforation, then surgical management becomes necessary. These surgeries are designed to stabilize the cornea, provide structural support, remove unhealthy or infected tissue, and actively promote healing.
What kinds of surgeries are we talking about?
Several options. One is a superficial keratectomy, where the surgeon carefully removes the damaged or infected surface tissue, essentially cleaning up the wound bed to allow for faster, healthier healing.
Okay.
A very common one for deep or melting ulcers is a conjunctival pedicle graft or conjunctival flap.
What's that involve?
The surgeon dissects a small flap or pedicle of the conjunctiva, that pink tissue lining the inside of the eyelids and covering the white of the eye, keeping its blood supply intact. This flap is then carefully stretched over the ulcer and sutured in place.
What does that achieve?
It does several critical things. It provides immediate tectonic support, like patching the hole. It brings a direct blood supply right to the ulcer, carrying nutrients, healing factors, and systemic antibiotics. And the conjunctiva itself provides antimicrobial and anticollagenase factors to help fight infection and melting.
That sounds ingenious. Are there others?
Yes, though less common. In very severe cases, corneal transplants using donor cornea or amniotic membrane grafts using processed amniotic tissue can be used. These aim to provide a scaffold for healing and potentially decrease scarring. And for those stubborn, indolent ulcers we talked
Which
about.
are ones that won't stick?
Exactly. Surgical debridement, often using a special diamond burr tool or a superficial keratectomy, can be performed to carefully remove that non-adherent hyaline membrane that's preventing the epithelium from sticking down. This essentially roughens up the surface and gives the new cells a chance to adhere and heal.
Okay, quite a range of interventions there. So once treatment begins, whether medical or surgical, what does the prognosis actually look like for a horse with a corneal ulcer? Is vision always saved?
That's a really crucial question, and honestly, the prognosis varies enormously. It really depends on the depth, the cause, whether infection is present, and how quickly treatment was started.
So best case scenario.
Best case. A superficial, uncomplicated ulcer caught early and treated appropriately, the prognosis is generally excellent. These often heal within 7 to 10 days, usually without any significant scarring that would affect vision long term.
That's good news. But the flip side.
The flip side, well, deep ulcers or infected ulcers, particularly those involving fungus, have a much more guarded to poor prognosis.
Why fungal specifically?
Fungal infections in the cornea are notoriously difficult to treat. The organisms can penetrate deep into the stroma, and antifungal medications don't always penetrate well. Treatment is often very intensive, prolonged, we could be talking weeks to months, and frequently results in significant corneal scarring, which can permanently impair vision.
So even if the eye itself is saved, the vision might be significantly compromised. That's a really vital takeaway for owners, isn't it?
Absolutely. Managing expectations is key. And those melting ulcers we discussed, they are true ophthalmic emergencies with a very guarded prognosis right from the start, simply due to the speed of tissue destruction and the high risk of the globe rupturing. In general, Corneal ulcers in horses tend to heal slowly compared to, say, dogs. And they have that strong tendency to scar and vascularize, develop those new blood vessels. Clients really need to understand that even if an ulcer looks like it's progressing slowly, the situation can change very rapidly. It can quickly worsen and progress to a descemetocele or a full perforation, if not managed aggressively.
So vigilance is key throughout the whole process. And what about potential complications down the road? Even after initial treatment seems successful, what else can go wrong?
Unfortunately, several serious complications can arise even later on. On the vision front, the most obvious is corneal scarring. Depending on the size and location, this can lead to permanent visual impairment, ranging from mild blurriness to functional blindness in that eye. Astigmatism, basically an irregular corneal shape due to scarring, can also distort vision.
Okay. What about infection-related issues?
Well, the infection itself can progress deeper, forming a corneal abscess, which is a pocket of pus within the stroma. Or, as we've said, it can lead to a descemetocele or outright globe rupture, perforation of the eye. If infection gets inside the eye, that's called endophthalmitis, or spreads throughout all the eye tissues, panophthalmitis, the prognosis for saving the eye, let alone vision, becomes very grave. Often, removal of the eye is the only option then.
Gosh. And internal eye issues.
Severe or chronic uveitis, that internal inflammation can be a major complication. If it's not controlled, it can lead to secondary problems like glaucoma, high pressure inside the eye, or cataracts, clouding of the lens.
And worst-case scenario for the globe itself.
If the damage is too severe or complications arise, you can end up with phthisis bulbi. This is basically where the globe shrinks, becomes non-functional, and atrophies. It leads to blindness and is often chronically uncomfortable, frequently requiring enucleation, which is the surgical removal of the eye.
It sounds like it really requires constant vigilance, even after the initial healing seems complete, especially with those tricky indolent ulcers we mentioned, where the new epithelium just struggles to adhere properly.
Precisely. That's a great way to put it. The core takeaway here, the thing to really hammer home, is simple but critical. Corneal ulcers in horses should be aggressively treated from the moment they are suspected, no matter how small or superficial they might seem initially.
Don't wait and see.
Absolutely not. Progression is common, and the consequences, as we've discussed, can be severe and potentially blinding or lead to loss of the eye. While advanced procedures like conjunctival flaps or corneal grafts can be necessary to save the globe and hopefully some vision, it's important, again, to manage expectations. These interventions themselves are often associated with some degree of permanent scarring.
We've truly taken a thorough look into equine corneal ulcers today, haven't we? Covered everything from the underlying causes and those telltale signs to the really intensive treatments required. It's just so clear that while these conditions are common, their potential severity means early, informed action is absolutely key.
It really is. And what stands out, I think, is the incredible complexity and maybe the surprising vulnerability of the horse's eye. Such a large, prominent feature, yet so delicate in some ways. Understanding these nuances really helps us appreciate why these ulcers can progress so rapidly and why every moment truly counts when it comes to diagnosis and getting treatment started.
So for you, our listener, thinking about all this, what's the one thing we really want you to remember from this deep dive? Perhaps it's just that vivid reminder of the fragility of even these incredibly strong, large animals. Or maybe the meticulous, often urgent care that's required to safeguard their health and specifically their sight.
hmm And maybe a final thought for you to consider, building on what we've discussed. Given that strong, sometimes problematic fibrovascular healing response, the horse cornea has the tendency to heal with vessels and scars. How might future advancements in veterinary medicine, perhaps in regenerative medicine or targeted therapies, learn to better leverage or maybe mitigate this natural healing tendency? How could we improve outcomes for severe corneal ulcers beyond the treatments we understand and use today? Something to think about.